All right, good afternoon and welcome to the Health and Human Services Committee. My name is Senator Ben Hansen. I represent the 16th Legislative District in Washington, Burke, Cumming, and now parts of Stanton counties, and I serve as chair of the Health and Human Services Committee. I would like to invite the members of our committee to introduce themselves, starting on my right with Senator Ballard.
Bo Ballard, District 21, Northwest Lincoln and Northern Lancaster County.
Good afternoon. My name is Lynn Walls, and I represent Legislative District 15, which is Dodge County and Valley.
I'm Murph Riepke. I represent District 12, which is southwest Omaha, part of that, and the good people of Ralston.
Also assisting the committee is our research analyst, Bryson Bartels, our committee clerk, Christina Campbell, and our pages for this afternoon is Peyton and Delaney. A few notes about our policy and procedures. Please turn off or silence your cell phones. We will be hearing 4 bills, and we'll be taking them in the order listed on the agenda outside the room. On each of the tables near the doors to the hearing room, you will find green testifier sheets. If you're planning to testify today, please fill one out and hand it to Christina or one of the pages when you come to testify. This will help us keep an accurate record of the hearing. If you are not testifying at the microphone but want to go on record as having a position on a bill being heard today, there are white sign-in sheets at each entrance where you may leave your name and other pertinent information. Also, I would note, if you are not testifying but have an online position comment to submit, the legislature's policy is that all comments for the record must be received by the committee by noon the day prior to the hearing. Any handouts submitted by testifiers will also be included as part of the record as exhibits. We would ask if you do have any handouts that you please bring 10 copies and give them to the page. We will be using a light system for testifying. Each testifier will have 5 minutes to testify. When you begin, the light will turn green. When the light turns yellow, that means you have 1 minute left. And when the light turns red, that means you have to stop immediately, otherwise we're going to yell at you. Okay. They're okay with it, I guess. When you come up to testify, please begin by stating your name clearly into the microphone, and then please spell both your first and last name. The hearing on each bill will begin with the introducer's opening statement. After the opening statement, we will hear from supporters of the bill, then from those in opposition, followed by those speaking in a neutral capacity. The introducer of the bill will then be given the opportunity to make closing statements if they wish to do so. On a side note, the reading of testimony that is not your own is not allowed unless previously approved. And as always, we have a strict no prop policy in this committee. So with that, we will begin this afternoon's hearing with LB 286 and welcome Senator Walls to open.
Oh my
Okay.
gosh, this is a tiny chair.
We should have, changed the chair out. So I still blame Senator Brewer for that.
It's
so.
all right. Thank you, Chairman Hansen. And this is a very complex, not simple bill at all.
Yeah.
Just kidding. I'm just kidding. This is a great bill. Good afternoon, Chairman Hansen. I can't even read this thing. And fellow members of the Health and Human Services Committee. My name is Lynn Walls, Lynne WALZ, and I represent District 15, which is made up of Dodge County and Valley. I'm before you today to introduce LB 286. The goal of 286 is to improve and protect mental health and well-being of the Nebraska physician workforce. I worked with the Nebraska Medical Association to introduce this bill, which will provide confidentiality protections around an existing physical wellness program in Nebraska. Reducing burnout and safeguarding the well-being and job satisfaction of the healthcare workers is an important part of retaining a strong workforce in our state. LB 286 aims to start by creating a safe haven for physicians to seek help with issues related to wellness and career fatigue. In 2021, the Nebraska Medical Association established the organization LifeBridge Nebraska. LifeBridge is a physician wellness program which aims to provide access to confidential and voluntary support for physicians seeking help with stress or other issues in a physician's personal or professional life. Those situations might include workplace conflicts, grief, depression, marriage, or financial stress. When a physician calls LifeBridge Nebraska, they are matched with a physician peer coach who is trained and ready to offer support. Any physician in Nebraska can use LifeBridge at no cost. Programs like LifeBridge are important because the environments in which physicians work drive high levels of burnout. Imagine working for hours in a trauma operating room only to have a patient die on the operating table at 1 a.m. Or being a new physician who may be juggling a young family while working 80 hours a week in a busy residency. Or consider physicians who have been practicing for decades, but who are suddenly having to change the way they practice to manage increasing demands of electronic health records. These scenarios are common, and unfortunately, they lead to physicians choosing to leave the practice. According to a 2021 report by Mayo Clinic, 1 of every 5 physicians intends to leave practice within 2 years, while 1 in 3 plan to cut back their hours. Despite the immense pressures physicians are under, they are often reluctant to seek help. A major reason for the reluctance is the fear that showing signs of fatigue or stress could have negative repercussions for the physician's career. These concerns are real. Physicians, along with other credential holders under the Uniform Credentialing Act, have mandatory reporting obligations. If a physician's peers become aware that a physician has acted unprofessionally, negligently, incompetently, or violated other regulatory provisions of the profession, they have a duty to report licensure at DHHS, which could result in investigation and disciplinary action by the Board of Medicine. While symptoms of workplace fatigue are not likely to rise to the criteria of reportable conduct, this fear is a very real barrier to physicians seeking support when dealing with stress and burnout. LB 286 provides confidentiality protections around Nebraskans' physician wellness program with the following provisions. First, it provides that an individual's participation in a physician wellness program is confidential and not subject to discovery, subpoena, or a reporting requirement to DHHS unless there is a danger to the public health and safety by the individual's continued practice of medicine. Secondly, individuals would not be required to disclose their participation in the program to any third party as a condition of employment, credentialing, payment, licensure, compliance, or other requirements. These changes will create a safe space through which physicians can seek and obtain confidential care in ways that will not have a detrimental impact on their careers. A number of other states have passed safe haven legislation to protect the confidentiality of their physician wellness programs, including South Dakota, Indiana, Virginia, and Delaware. LB 286 is modeled after the legislation passed in those states. It also closely mirrors the protections currently in Nebraska statute for the Licensee Assistance Program, which is a substance abuse program for licensing under the Uniform Credentialing Act. It also mirrors the protections in Nebraska Supreme Court rules for the Nebraska Lawyers Assistance Program. There are testifiers behind me who could speak more to the need for LB 286. In conclusion, I'll just say that Nebraska needs its physicians, especially as we look at the rural areas where access to care is increasingly difficult. LB 286 is a small change that will help keep physicians healthy, productive, and practicing here in Nebraska where we need them. Thank you.
Thank you for your opening testimony. Are there any questions from the committee? Senator Reeve.
Thank you for presenting this bill. Do you anticipate that telehealth would be part of this? Because you talked about the rural and
Right.
remoteness of it and maybe the confidentiality. I assume that might be part of it.
You know what? Let me find out
I'm just
the answer to
curious on
that.
that.
Sure.
My other question is there's at least my fiscal note shows 0. So this is legislation just to protect the confidentiality of it.
Yes, it's not starting a new program. We already have a program in place.
Okay. The other question that I have, Mr. Chairman, is what about RNs? And I know in the hospital business, we have programs that are allow everyone
Right.
employed by the hospital. A number of physicians are employed by hospital systems anymore. They would have access to that. So I'm trying to sort out what makes a physician program different than maybe a program where nurses
Or
participate
nurses.
in, or
Right. Let me find out about that one too.
I'm just curious. Thank you for being here.
Thank you, Senator Reedy.
Any other questions?
They don't have this kind of program for administrators, I assure you.
For who?
For administrators.
I'll write that one down.
They probably need to.
Yes.
Okay, thanks.
Thank
Seeing
you.
none, thank you. Our first proponent. Just hand your green sheet to the page. Thank you. Welcome.
Good afternoon. Chairman Hanson and members of the Health and Human Services Committee, I appreciate the opportunity to be here. My name is Todd Stahl. I'm a physician. I've been in practice for about 30 years. I've treated physicians for a number of years. My specialty is psychiatry and addiction medicine. So I appreciate the opportunity to talk
I'm
a little
sorry,
bit
could
about-
I have you
Oh,
spell your name?
TODDSTULL.
Thank you.
So I appreciate the opportunity to discuss the matter today at hand. That's LB 286. To provide a little context in this bill, I'd like to share some information, and you've heard some of this already, so I'm not going to repeat what's been said, or hopefully not, but there's a number of physicians that are really struggling now with burnout. If you look at the data, it's between 40 and 60%, 60 to 65, depending on the specialty. Emergency medicine is pretty high, and they're into the 65% range. In Nebraska, contextually, when you think about this, we have about 12,500 licensed physicians, and about 5,500 of those live in the state of Nebraska. Of the 93 counties, 65 of those counties have less than 10 physicians. And so I bring that up because I want to talk about a couple other issues that are related to why we're supportive of this, of LB 286. You've heard a little bit about burnout. Burnout is the idea of being exhausted, demoralized, if you will. It's an element of being disconnected and being less productive, especially in the healthcare setting with physicians. That compounds burnout are a number of principles that erode kind of within a healthcare system. And so we knew burnout was going on for a long period of time. And now when you look at burnout associated with physicians, about 1.5 to 2 times there's a greater likelihood of physicians leaving practice. And you heard this earlier in the opening kind of testimony. Many physicians are working less hours. And about, if you think about the 1 in 5 is thinking about leaving medicine altogether. Let me give you numbers. 117,000 physicians left practice in 2021 due to what we're talking about. Only 40,000 entered practice. So it's a major issue when we're talking about healthcare. This impacts rural communities even more so than some of the other communities, because when a rural physician leaves, there's a number of jobs that are created by that rural physician. And to recruit and train and maintain a physician is not only difficult, but it costs the system about $1 million. In family medicine, so a family doctor out in practice, if you look at burnout rates 10 years ago, they were about 47% in family medicine. After COVID, they've gone up to about 57%. So LifeBridge, the program that I'm the medical director for, is a program that's a wellness program. It is supported by the Nebraska Medical Foundation as well as the Nebraska Medical Association. It was created by physicians and designed by physicians, and the physicians are the ones who are the coaches to help other physicians. Any licensed physician in the state of Nebraska, whether you're in residency or out in Scottsbluff or Chadron or wherever, can use this program. And the way they access it is by calling a confidential 800 number. And many times they will access it to address issues with, you've heard the burnout, but also maybe system problems, work-life balance problems, communication problems, or just wanting to figure out how to grow and expand. And I don't have time to go into more details, but it's clearly a preventative program that's designed to help physicians that are not only struggling, but prevent the struggles that they may get into along the way. And when you think about the program, others come into it because they're in transition and they may want to transition out of practice or into a new job. So it can be used from that aspect as well. There's some hesitation about physicians using this program or reaching out, largely related to stigma or who's going to find out, so the confidentiality piece. And also, it adds time potentially onto what they're doing. So there's concern with, wow, this is going to take up more of my time in this process. We know that many physicians, as they become demoralized within this process of where we're at with healthcare, it's a multifactorial issue. And they feel like if they have to add something else on, that can be stressful. But in the reality of this is, if they address some of the concerns and learn new strategies, it can be very helpful to preventing them from deteriorating further or struggling further. Many individuals will call the 800 number, as I mentioned. However, they can call directly into the program and access it by talking to a physician in the program, or being paired with a physician in the program.
You have the red light. Could you just wrap up your thoughts for us?
Yep, I sure can. So we know the utilization rate is a little bit lower than what we'd like it to be. And we found that the states that implement the safe haven law, their utilization rates go up. If utilization rates go up, we hopefully will have that preventative strategy to prevent some of the burnout and other issues that take place. So it's really about physician well-being and health.
Thank you. Are there any questions? Yes, Senator Reapy.
Thank you. What's your funding source?
Funding source comes from the foundation at the Nebraska Medical Association and several hospital systems and insurance companies so far.
Okay.
We have pretty widespread support. They recognize the importance of this.
I'm going to take a little point of privilege here in the sense that in 2015, I think I introduced direct primary care, which was quite frankly the same factors which resulted in physicians getting burnt out with the idea that they could do direct primary care, control their own lives, and doctors and Strata Healthcare has been very successful, and I think it's one of the options for state employees.
It's been very successful.
Well, I don't know that it's been grandly successful. It hasn't
Well,
taken
I'm
over
very
the
familiar with
cross,
it.
but
I know Joel quite well,
You know Joe best.
quite well.
Good man.
And so, yes. And so I'm glad you brought that up, Senator. I appreciate that. Yeah.
Well, I'm glad we had Joel around to be a perfect person to be the model.
Yes, well said.
But anyway, thank you for your concern. We do have to take care of everyone, including our physicians.
It's easier to take care of patients if you take care of yourself first.
Well, and sometimes I think, excuse me, Mr. Chair, we think they're maybe superhuman, and so that like other people, they don't have problems.
Yeah.
We all do. Okay, thank you.
Thank you.
Thank you.
Thank you, Chair.
Any other questions? Thank you for your testimony. We'll take the next proponent. Good afternoon.
Good afternoon, Vice Chair Kavanaugh and members of the Health and Human Services Committee. My name is Daniel Rosenquist, DanielRosenquist. I'm a family physician in Columbus and the current president of the Nebraska Medical Association. I am here to testify in support of LB 286 on behalf of the NMA. The NMA would like to thank Senator Walz for introducing LB 286 and for recognizing the need to address physician wellness in Nebraska. As a practicing physician in Columbus, I can tell you the concerns about burnout, career fatigue, and wellness are very real. Physicians work long hours, the demands continue to increase. Family obligations, responsibilities to patients, administrative burdens, all of these things take a toll, in addition to dealing with the matters of death, disease, and chronic conditions. What Senator Walz and Dr. Stoll stated in their testimony is true. Physicians are reluctant to ask for help when they're struggling. I was in a conversation with one of my rural colleagues earlier this week. They told me that they actually counsel 6 people from the metro area because they are afraid to seek the mental health that they need in their own community. That is just the impact that this type of thing has, and this is where the need for all of this protection. They are concerned about the potential repercussions of being treated. LB 286 is a step toward reducing the stigma and the worry from physicians asking for help. I think this is just a small thing, just adding the physician wellness program to some protections that already exist in statute for other programs, but it could have a positive impact as Nebraska does its best to retain and recruit a skilled and healthy physician workforce. Thank you for your time, and I'm happy to answer questions.
Thank you, Dr. Rosenquist. Senator Reapy.
Thank you. I assume that this comes before any reporting to the National Data Bank.
Because there's not an action by the state or in a court of law. So yes, it does.
So it's trying to help the physician before it puts a black mark, if you will, on his or her record.
It's actually helping a physician say, you know, I think I may have some problems. I'm struggling here, and can I find some help? Is there anybody else who's experiencing the same type of feelings that I have?
Can partners, assuming, I think the most dangerous one, solo practice, at least historically said that, can partners, I suppose they can intervene and recommend, but the person has to want to come. My question would be though, are spouses or significant others allowed to participate in the program?
At this time, we only have this set up for physicians. We would like, and what we're here to ask for is the protection from discovery for physicians.
Oh, okay.
Would like to, as a program, we would certainly like to involve those people because that's probably the most supportive individual for that physician.
Yeah. Okay. Thank you.
Thank you, Senator Reapy. Any other questions? I would like to just note, do you still have an active practice?
Yes, I still practice 3 days a week.
Wow, because you are very active for this committee, which I appreciate, and just wanted to note that it doesn't go unnoticed that you keep showing up for your medical community, and I hope that your membership is noticing as well.
There are probably 6 physicians in Columbus who would like to hear you say that because they're feeling the same way.
Well, thank you so much for
Thank you.
showing up and testifying.
Thank you.
And we will take the next proponent testifier. There is one. Okay. And is there anybody in opposition? Is there anyone in the neutral capacity? Seeing none, Senator Walz, you're welcome to close. And as you close, we have 2 proponent letters for LB 286.
Can you see me?
I can, sort of.
I'm just going to make it very quick. I just want to thank the testifiers for coming today and educating us on the physician wellness program, as well as the very, very important role confidentiality plays in physicians being able to access care and the protection that it provides for physicians. So thank you very much.
Thank you, Senator Walz. Are there any questions from the committee? Seeing none, that will close the hearing on LB 286, and we will open the hearing on LB 326. We are just switching the chair out.
Oh, there you go.
And we will welcome Senator Raybold for LB 326. Welcome, Senator.
Good afternoon, colleagues. Whoops. I got the extra low seat. Is that?
No, we just switched it. Actually,
That's
this is higher.
I can barely see Senator Reapy.
Lucky you.
I know, right? Well, my notes say good morning, but it's actually good afternoon, colleagues, and certainly Vice Chair Kavanaugh and members of the Health and Human Services Committee. My name is Jane Raybold, and Jane is Jane, and Raybold is Raybould. I represent Legislative District 28 and appear before you today to introduce LB 326. LB 326 would change the continuous eligibility for children and youth under 18 years of age in the Medicaid system from the current 6 months to 12 months, ensuring no disruption in healthcare services. Currently, federal Medicaid law allows states to adopt a 12-month continuous eligibility for children and youth age 18 and under from very low-income households. 33 states, let me say that again, 33 states have implemented this option, including the surrounding states of Iowa, Kansas, Colorado, and Wyoming. Nebraska does not, and Nebraska requires a review of income eligibility of parents every 6 months. This does not require a state plan amendment or a Medicaid waiver, but rather the state has to check a box on a form submitted to the Centers for Medicare and Medicaid Services. Just check a box. 12-month continuous eligibility for low-income children and youth to continue to have access to healthcare throughout the school year and summer months is a proven strategy. It protects against lapse in services because parents fall through the cracks. They do not get notices because of a move, they don't get the forms submitted in time, or have a fluctuation in income through the year. Continuity of care improves health outcomes, keeps kids out of the emergency rooms and other costly hospital care. Without coverage, families forego preventative visits or filling prescriptions. Children and youth without gaps in coverage are 25% less likely to have a preventable hospitalizations. I would like to take a moment to address the fiscal note for LB 326, which places a very large price tag on implementing continuous eligibility. LB 326 is intended to fill the gap, not the whole year, the gap between now and January 1st of 2024, when all states will be required to adopt 12 months of continuous eligibility for children. The fiscal note includes additional costs after January of 2024, when continuous eligibility for children will be required in all states. The department's analysis claims that adopting LB 326 will increase the total spending by $57 million for the remainder of the fiscal year. Given the experiences in states that have enacted continuous eligibility, this estimate seems wildly inflated and fails to account for any administrative savings or the savings you would see for children who don't have to be rushed to the emergency room. I can't think of a more important investment for us to make than a proven strategy like LB 326 that protects children and youth, particularly as we have seen such a crisis in mental health needs. And with a bipartisan vote, so does the U.S. Congress. Last fall, they included 12-month continuous eligibility for children in the Medicaid systems of all states by 2024 in their omnibus budget legislation passed this past December. I believe it is important that we implement this common sense move now and invest in these children and youth who will be the future of our state. Thank you for your time, and I will be more than happy to answer any questions.
Thank you, Senator Raybold. Do we have any questions from the committee? Senator Reedby,
Thank you. Chairwoman.
he's over here.
I can see if I really,
You can see, maybe my white hair, you can see that. My question would be, may I ask, who asked you to bring this legislation?
I'm trying to remember the organization because we've worked on so many legislative bills. I don't know if it was the hospitalization or First Five, being an advocate for young children, but it's one that I wholeheartedly support.
Okay. You said some magical words when you said continuity of care. That's always good. Thank you.
You're welcome.
Do we have any other questions from the committee? I have some questions.
Hey, you can see me now.
Yes. So the fiscal note, did you have any conversations with the department about the fiscal note? I know they get them to us probably this morning, but.
Yes, I did. And as a matter of fact, I met with Director Commissioner Kevin Bagley. And I think when they initially did the fiscal note, they were looking at not only fiscal year 24 from January 1st to December, they were also looking at the gap. And I don't know if you have a copy of the fiscal note, but The fiscal note just pertaining to that gap, which would be for this year from October 1st through December 31st, 2023. The gap really is only $16 million, but you have to, that's total $16 million, of which almost 10 million of that is federal funds.
Mhm.
So, and if you want to look at the total outcome, you have to also consider the funding that CHIP provides as well. So in totality, if you really want to look at it, you can look at it, the general funds would be a total of $7.5 million, not the 57 million, but 7.5 million. And I think it's a common confusion. They think that they have to fund the continuous eligibility from where that gap ends, but it's really only from that period of October until January 24th, when they're obligated to fund it no matter what.
And just for historical context, we have actually been doing continuous 12-month funding for the last 3 years.
That is correct. Because of the pandemic, that was one of the requirements to safeguard families in trying to get through the public health crisis.
And in doing the 6-month eligibility, that is a choice that the state is making. We are not required to do the 6-month eligibility.
Yes, we're one of the few states that does a 6-month eligibility. For the most part, it's routine and customary for all the states to do that 12-month.
And so, and beginning in January 2024, we are required to do a 12-month eligibility.
That's correct. And I
Okay.
think what they're seeing is that family members, if they relocate, trying to come up with the records, some families struggle if they have to show any increase in their income. They have to try to figure out how to get a pay stub, since most people do direct deposit. And so it creates a tremendous amount of hardship for that parent to try to regather all the documents to be able to make their case so that their child continues to get the care and treatment that they need.
And the 7.5 million, oh, sorry.
No, you
Okay.
go right ahead.
The 7.5 million, is it your understanding that that is coverage for all children that would qualify for that 6-month period? Or is that for children that might not qualify? So if we don't, if we did the 12 months without doing the renewal,
Mhm.
and there could be a portion that no longer qualify during that 6 months, is this 7.5 million to cover those that would otherwise not qualify?
Well, that 7.5 million includes the 6.8 from our general funds, from
Right.
Medicaid, and then 736,000 from CHIP.
I guess what I'm asking is, and you don't have to actually answer this is maybe more a question to put into the ether for others, perhaps can answer. That 7.5 million, is that covering all of the children for that 6-month period,
It is
whether they qualify or don't qualify?
It's my understanding the answer is yes.
Okay, so we have some math problems with our fiscal note, but I'm going to turn to Senator Reedy.
Well, thank you, Senator. I'm very proud of Senator Kavanaugh. She's become a fiscal hawk here. My question is kind of a follow-up to that, is the 7.5 million, that's what I would call the first payment, but then subsequently to maintain it, there's every fiscal, so over 20 years, it's 7.5 million times X. So it's kind of and my only concern there is we have money at this time. I'm not sure we'll have money in 3 years or 5 years or whatever.
Well, I
So you
think,
take on added entitlements, added responsibilities, and we have to make sure, I've lived through the legislative period of time when we were told never bring a bill to the floor if it had a fiscal note. That's how poor we were. So you were there too. And it was bleak.
well, I think one thing we need to keep in mind that there are federal matching funds. So for even through the end of this year, 2023, from our general funds, it's 7.5 million, but the federal funds are about 11.5 million. So
To get that 11.5, we're gonna have to come up with our 7.5.
that is correct. But starting January 1st in 2024, we are obligated, federally mandated, all states to provide that continuous coverage eligibility.
Okay, I don't want to, that's a whole nother debate, but thank you very much.
You're welcome.
Thank
My
you.
fiscal hawk friend.
I'm glad you picked up on that. Are there any other questions from the committee? Seeing none, are you going to stay to close?
I think I can.
Are you where I don't see in the room if the department is going to be coming to testify? Okay, well, we will then follow up
Okay.
with the department with some of these questions. Our first proponent for LB 326. Welcome.
I feel special that I get the big chair. I was getting invested in what was happening. Good afternoon, Vice Chairwoman Kavanaugh and members of the committee. My name is Amy Binke, AMYBEHNKE, and I'm the CEO at Health Center Association of Nebraska. I'm here today on behalf of Nebraska's 7 federally qualified health centers who collectively serve over 113,000 patients statewide. HCAN stands in strong support of LB 326, which would have Nebraska Medicaid provide 12 months continuous eligibility for children. 12-month continuous eligibility is a proven method to increase enrollment in Medicaid, ensure continuity of coverage, limit administrative burden, and eliminate red tape. And I also, with the handouts, do have a letter of support from the Nebraska Child Health and Education Alliance as well. Throughout the year, children turning on and off the Nebraska Medicaid program is a common occurrence. More often than not, this churn is due to administrative burden. Losing insurance coverage due to red tape happens far too often for children living in poverty and disproportionately impacts children of color. Although coverage for Medicaid is intended to last for 12 months, additional income reviews can be requested by the state at any time during this coverage. In 2019, pre-COVID-19, about 12,400 children were disenrolled from the Medicaid program due to periodic income checks. However, according to data submitted to the department to CMS, 72% of those children who were disenrolled by the state were disenrolled because they did not properly fill out requested paperwork, not because they did not qualify. Paperwork should not cause children to lose their insurance coverage. At one of our centers, One World Community Health Centers in Omaha, over 1/3 of their patients are children. Their parents are hardworking individuals, often working multiple jobs to support their families. Among low-income workers, seasonal or monthly variations in income are very common and can cause interruptions in insurance status. These people are not hitting the lottery. They have minor variations in their income that trigger a cumbersome income verification process. Providing income verification is also not easy for many low-income families, especially those that have low literacy or limited access to technology. A common barrier is getting proof of income if you have direct deposit. Many employers no longer give employees pay stubs, and they need to figure out a way to create an email account and then register and negotiate an electronic payroll system. They need to find access to a printer. Another challenge occurs for people who change jobs. If the state still has your previous job information in the system, you need to work to get your former pay stub employee coverage. You'd have to go back to your previous employer and ask them for a letter verifying that you no longer work there. That can be hard to do, especially if you quit or were fired. In the end, many families get stuck in the process and children lose their insurance coverage. Because no one lost coverage during COVID-19 public health emergency, we were able to witness the impact continuous coverage has on our patients. Nationally, the uninsured rate for children dropped, reversing a multi-year trend of the number of uninsured children actually going up. At One World in Omaha, we saw the uninsured rate for children drop from nearly 30% pre-pandemic to 24%, the lowest it has ever been at that health center. Continuity of Medicaid coverage is essential to continuity of health care. Children with gaps in coverage are more likely to skip well-child visits. They are unable to afford medications or access to specialty and behavioral health care. Children with gaps in coverage are nearly 25% more likely to have preventable hospitalizations. As Senator Raybould mentioned, beginning January 1st, 2024, all states will be required to provide 12 months of continuous eligibility for children enrolled in Medicaid and CHIP. LB 326 merely bridges that gap until then. Adopting 12-month continuous eligibility now will help more low-income Nebraska children keep their Medicaid coverage in order to stay healthy. I'd like to thank Senator Raybould for introducing this bill and thank the committee for your time and encourage your support of LB 326. I'm happy to answer any questions.
Thank you for your testimony. Are there any questions from the committee? No. Wow. Are we sure?
That's my voice.
Okay. I do have some questions. So as you heard discussing the fiscal note, my favorite topic,
As it should be.
there appears to be an assumption that all of the children currently covered on Medicaid, on CHIP, would not qualify for that final 6 months. Does that seem accurate to you?
So the experience in other states is that they see about a 2% increase in their enrollment and in their costs when they adopt continuous eligibility. So looking at the numbers, not being a mathematician, but kind of doing back of the envelope math, this seems high, especially for 3 months for the end of the year.
Okay, thank you.
You're welcome.
Any other questions? Seeing none, thank you for your testimony. Do we have any other proponents for LB 326? Welcome.
Thank you. Good afternoon, Vice Chair Kavanaugh and members of the Health and Human Services Committee. My name is Kelsey Ahrens. That's KELSEYARENDS, and I'm the Healthcare Access Program Staff Attorney at Nebraska Appleseed, testifying in support of LB 326 today on behalf of Nebraska Appleseed. We are a nonprofit legal advocacy organization that fights for justice and opportunity for all Nebraskans. And one of our core priorities is working to ensure that all Nebraskans have access to quality, affordable health care. Nebraska Appleseed supports LB 326 because continuous eligibility promotes children's health while decreasing healthcare system costs, unnecessary coverage losses, and administrative costs. Frequent changes in Medicaid eligibility, known as churn, interfere with the continuity of care for enrollees, which results in high healthcare costs and increases administrative burdens for providers, managed care organizations, and state agencies. Ensuring consistent coverage for kids who have Medicaid is particularly important right now, as you've heard from previous testifiers, as state Medicaid agencies are preparing to resume normal operations and unwind from COVID-19 related protections. Since March 2020, federal law has generally required states to keep most people with Medicaid enrolled in coverage, regardless of changes like changes in income during the federal COVID-19 public health emergency. Recent federal legislation has set an end date to the COVID-related continuous coverage requirements. States can start processing fresh renewals for all Medicaid enrollees this spring. Terminations may start as soon as April 1st, 2023, and are likely to continue for a full year in Nebraska. The federal government has provided guidance to states, encouraging implementation of strategies to help eligible individuals maintain their coverage, prevent churn, and mitigate procedural denials, including recommending a state plan amendment or other action to implement continuous eligibility for children as proposed under LB 326. Procedural disenrollments occur when the state agency does not have enough information to process an enrollee's renewal, meaning that for a lack of information, as opposed to actually not meeting the eligibility criteria, the person is terminated from coverage. Historically, many individuals who lose coverage for procedural reasons remain eligible for Medicaid, but become uninsured. The risk for children is particularly high. A recent study by federal HHS projected that more than 72% of children who are predicted to lose Medicaid coverage during this unwind period will be terminated even though they are still eligible. Healthcare disparities based on race and ethnicity are expected to be exacerbated during this process as well. The same study projected that Latino enrollees will be more than 3.5 times as likely as white enrollees to be terminated despite remaining eligible for their Medicaid coverage. Additionally, as you've heard, new federal legislation requires states to implement continuous eligibility for kids as of January 1st, 2024. Implementing continuous eligibility as soon as possible, even multiple months before the federal implementation date, will provide for additional stability and coverage throughout the unwind of the COVID-related continuous eligibility protections for Nebraska kids. Separate from the COVID-related unwind concerns, as you've heard, continuous eligibility helps children maintain consistent care, which in turn helps them succeed in school and keeps the state's communities healthy. When children have consistent healthcare access, they're able to regularly access preventative services like vaccines, well child visits, and other age-appropriate care. Keeping children covered also helps providers develop relationships with children to better manage their care and monitor their development. On the other hand, there's evidence that changes in coverage are associated with increased emergency room visits and result in higher healthcare costs. Guaranteeing continuous eligibility for low-income children also helps combat unnecessary coverage losses and gaps in coverage. There's ample evidence that paperwork, periodic checks, and inadequate notices can cause eligible individuals to improperly lose coverage. The rates of churn are lower in states that have already implemented 12-month continuous eligibility at 2.9% compared to 5.3% in states without continuous eligibility policies. This bill would reduce unnecessary loss of coverage and would be less burdensome for families. Because this bill encourages continuity of care, better health outcomes for children, and provides for administrative efficiencies, Nebraska Appleseed supports this bill.
Thank you for your testimony. Are there any questions? Yes.
Excuse me.
Yes.
How does the CHIP program for, and I should know this, I suppose, but how does the CHIP program contribute or detract from this?
So CHIP, both Medicaid and CHIP, both programs will be required to implement continuous coverage under the new federal legislation, and I believe under this bill as well. So the difference between Medicaid and CHIP practically for kids who get to enroll is that the CHIP income limit is a little bit higher, and the federal match rate for CHIP is also higher. So more federal funds come in to pay for the CHIP program.
Okay, thank you.
Yeah.
Thank you.
I have some questions. So first of all, I'm continually asking about the fiscal note. Have you had a chance to see the fiscal note?
I've seen it.
Okay.
I'm not sure I have any new information for you.
Okay.
But you can ask. I'll tell you if I don't know.
Well, I'm just trying, it is very unclear to me, and since I don't have the information in front of me as to what this program costs for 6 months regularly, it's unclear if the 7,500 in the fiscal note for the remainder of 2023 is for all children, or if it's just for the children that the department is assuming would no longer be eligible. And I don't know if you have a sense of that.
I don't have an answer for you.
Okay.
I think we'd be very interested in that
I'll
as
just
well.
keep asking it, and then maybe the department will show up and answer the question. That's kind of what I'm hoping. But I'll just keep on asking. Thank you so much. Are there any further questions?
If I could, I would just note, as other testifiers have said, but just to say again, the costs will be just required very quickly after this would possibly be implemented. So the costs are going to be what they're going to be, but they'll be required as of January, whether this bill passes or not.
Oh, and I did want to note, you mentioned administrative costs, and I just wanted to note for the record that I don't see a breakout of how much more it would cost administratively in the fiscal note. So perhaps an oversight by the department to include those costs. But thank you so much.
Yes, and just to, if it's
Yes,
okay
no,
to follow
go-
up on that,
go
yeah.
right ahead.
We do know that states have seen administrative cost savings based on implementing continuous eligibility because of, we know state agencies spend time diligently reviewing eligibility. And so that time, if you don't have to do that every 6 months, saves a lot in administrative costs as well.
Maybe we will see that in an amended fiscal note. Thank you.
Thank you.
Do we have any other proponents for LB 326? Welcome. Oh my,
Promise it's not a problem.
not a prop.
It's candy.
It's candy. If you want to hand to our page, she can distribute when she's able. Welcome.
Thank you. Oh, wait a second to pass it out.
No, you go ahead.
Okay.
Yeah.
Members of the Health and Human Services Committee, my name is Garrett Swanson. That's spelled Garrett Swanson, and I'm here on behalf of the Halloween Children's Movement in support of LB 326. Last year, our sister organization, the Holland Children's Institute, conducted 55 pages of research to develop policy options for the legislature to consider in relation to Medicaid in public schools. After months of development, we boiled down our research to 3 suggestions for the legislature to consider. LB 326 is our second suggestion, which you can find an in-depth analysis on page 32. Senators, children are particularly sensitive to change in their formative years. Frequently changing eligibility status cycles children on and off of coverage, a phenomenon known as churn. In many cases, churning children are disenrolled despite becoming eligible again soon after disenrollment. Unstable, changing levels of program and service availability due to lack of continuous eligibility hinders continuity of coverage and negatively impacts a child's ability to thrive. In 2003, Washington State replaced its 12-month continuous eligibility with a 6-month continuous eligibility like we have here in Nebraska. The results were so profound, this resulted in more than 30,000 children losing coverage in the following 2 years. This consequence was so profound that in January 2005, Washington reversed that decision, reverting to its 12-month continuous eligibility period, resulting in 30,000 children gaining or having coverage restored by the end of the year. Nationally, with historic and chronically low early and periodic screening, diagnostic, and treatment performance, changing children's health coverage further complicates the ability to coordinate with providers and deliver required care. For disenrolled families, Nebraska does make transitional medical assistance available to qualifying families who no longer meet Medicaid and/or CHIP eligibility requirements for a period of 6 months. TMA may be used for both adults and children. TMA is an attempt at addressing unintended policy consequences, commonly known as the cliff effect. The cliff effect refers to a sudden and often unexpected revocation of income-linked benefits such as Medicaid or CHIP. Often a modest increase in a family's annual income can and does see some or all eligibility and associated benefits. Because of this, heads of household frequently decline incremental opportunities for professional advancement as a small increase leads to a loss of benefits that far surpasses the increased wage. As a result, instead of a ladder out of, it can become an anchor into poverty, trapping beneficiaries in a cycle of systemic poverty in which there's no way to bridge the gap between advancement and household stability. While continuous eligibility can ostensibly increase state costs, the cost burden is primarily related to keeping children covered. Continuous eligibility is one of the most effective strategies a state can take to ensure eligible but uninsured children are enrolled. When implementing 12-month continuous eligibility, we should expect a decrease in health costs over time by ensuring better continuity of preventative and interventive care for children and a reduction in churn, and reducing administrative costs of processing frequent eligibility determination, enrollment, disenrollment as children and families cycle on and off of Medicaid and CHIP. Extending the term of continuous eligibility paired with existing TMA program would allow Nebraska to better address the cliff effect for Medicaid and CHIP coverage. In a national study, nearly half of U.S. children who were disenrolled from Medicaid re-enrolled within 1 year, with higher risk demographics having shorter Medicaid enrollment gaps, but more likely to have instances of Medicaid enrollment. Continuous eligibility alleviates this churn and ensures consistent coverage for children during years of important physical, physiological, and social emotional development. The Holland Children's Movement strongly urges this bill to be voted out of committee. And just as an aside, our third policy recommendation is actually Senator Day's LB 85, and we thank you very much for that.
Thank you. Are there any questions? Seeing none, thank you for your testimony.
Thank you.
Do we have any other proponents for LB 326? Seeing none, do we have any opponents for LB 326? Seeing none, do we have anyone in the neutral for LB 326? No neutral? Okay. Seeing none, Senator Raybould, you are welcome to close. And as you do, I will say that we have 14 proponent letters for LB 326. Thank you, Senator Raybould.
That's terrific. Thank you very much. And so I heard some questions that we all agree that the estimate or the fiscal note provided by HHS is a little out of whack. And I know Ms. Benke in her testimony said that really the states that have already adopted the 12-month eligibility have experienced an average of 2.2% increase in the cost. And that's really in reference to that gap where those kids may have fallen off. So that's how you have to calculate. You shouldn't be calculating it for the entire year. And then, so if you look at that 2.2%, really it should come out to about 5.5 million in general funds for the gap instead of what HHS had come up with the 7.5 million. And it could be even more because I'm just kind of calculating as I go. So
Well, thank you. Are there any questions from the committee? I would just note that we have in the past seen departments come in with a revised fiscal note. So perhaps that's something that we can expect from DHHS on this particular one. But
well, and I think so. After having conversations with Director Bagley, he said, I get what you're seeing, I get what you're saying, and I think we can come back with a revised fiscal note that more accurately reflects the gap. And I think it's a common mistake for other states that have done it. They just give you that big whole year. And this is how it looks pretty scary, but it's only that gap.
well, thank you so
thank you
much. And
Thank
that-
you all very much.
This
Appreciate it.
closes our hearing on LB 326. And we will open our hearing on LB 468. Welcome, Senator DeBoer.
Hello. Vice Chair, Second Vice Chair, Senator Kavanaugh.
Third Vice Chair.
My name is Wendy DeBoer. Thank you to the Health and Human Services Committee. My name is Wendy DeBoer, W-E-N-D-Y, D-E-B-O-E-R. I represent the 10th Legislative District in Northwest Omaha. I'm here to introduce LB 468. Last year, as a part of LB 752, the HHS Community Priority Bill, we passed a bill that I had added onto it, the creation of the Alzheimer's Disease and Other Dementia Advisory Council. Due to staffing concerns at HHS, the council, although it was appointed by Governor Ricketts, has been as yet unable to meet, which is why I introduced LB 468 to address those staffing concerns. Having a specific person inside of DHHS to work on Alzheimer's and other related dementias is vitally important. I was pleased to see, as part of the governor's budget, the inclusion of a staff member in DHHS to do this work. And following a conversation with the department, I do believe that this staff person will meet most of the needs of the council and Nebraska. There are a few areas that we talked to the department about that we would still want to have covered as well, and they believe that they can. So as such, I'm requesting the committee to hold the bill, and should we need to further support them next year with more efforts for dealing with Alzheimer's and other related dementias, we have this bill as a starting point. And in the meantime, I would ask you to hold it. I'm happy to answer any questions you may have. I will waive closing because we're a little shorthanded in judiciary and I gotta get back over there.
Thank you, Senator DeBoer. Do we have any questions from the committee? Senator Reapy.
Thank you, Senator. My question would be this is, do you know who in, because it's a function that's going on with Alzheimer's and dementia. Is there someone that's designated that you're aware of within DHHS who's now performing that function?
There isn't yet, but the governor's budget had the provisions to add someone to do that work.
But I struggle to think that someone's not paying attention to, because it is a significant issue.
It is a significant issue and
So somebody in there has to be doing it.
so there is a Department on Aging, but they don't, they're all issues regarding aging. So it's just something that we haven't had. We're adding it in now. I'm so
Okay.
glad the governor was, recognizes the importance of this issue and was able to prioritize that. And we do have this council, which we have asked to update the state plan, which is, 10 years old or something. And that new council will be meeting, so they will be focusing on that. So while we do not yet have all the resources in place, we're close. We're going to get them together.
Does the fiscal note match up with the governor's budget piece?
I'm not 100% sure exactly how they match up, but I think that whatever's in the governor's budget is obviously what we're going to do
Okay.
right now. And if we need additional resources, then I may be coming back to this committee
Okay.
next year.
That assumes as well that we do adopt the governor's budget,
Yes, I'm sorry.
because we'll come up with our own.
I am so sorry. I misspoke.
No,
Assuming we adopt the governor's budget.
My other piece on fiscal note, it says that 81,500 in fiscal 23-24. I think that's a low number. My experience is you get a director, you get an associate director or a deputy director, you get a support person, you're talking more like $250,000 for every director position. I don't care where it's in state government or in the private industry. It all pyramids.
Senator Rupert, I'm glad you brought that up. One of the things that, were we to pursue this bill now, we had an amendment that would change that from director level position to just a point person. So that would have changed from our original request in the green copy to just a point person within the department. And that probably would match more with the fiscal note that you're referencing.
Maybe bring them in at an AA salary.
Hopefully not.
Thank you, Senator Reapy. Are there any other questions from the committee? I, just following up with what Senator Reapy said, if we do not adopt the governor's budget, as Senator Reapy has indicated as an option available to us,
Of course.
then perhaps you'll come back to us about moving this bill forward this year.
Absolutely.
Okay, well, thank you, Senator DeBoer, and we will take our first proponent testifier.
All right, thank you.
Welcome.
Good afternoon. I'm Nick Faustman, Nickfaustman. I'm the Director of Public Policy and Advocacy at the Alzheimer's Association Nebraska chapter. The Alzheimer's Association is the leading voluntary health organization in Alzheimer's care, support, and research. Our vision is a world without Alzheimer's and all other dementia, and we support LB 468. There are currently 35,000 Nebraskans over the age of 65 living with a diagnosis of Alzheimer's, and that number is expected to increase by nearly 15% in 2025. And so it's easy to see that the coordination of state programs for people with dementia is absolutely critical. Currently, there are staff at DHHS designated to the other chronic diseases, asthma, arthritis, and cancer, just to name a few, but there is no designated staff for Alzheimer's or dementia. The lack of coordination hinders the ability of our state to evaluate the effectiveness of policy efforts that serve this population. It will also hinder the implementation of future policy solutions. That is why we are advocating for the creation of a position at the Department of Health and Human Services to serve as the point for all things dementia. The position need not be a director's level staff, and whether the position is called a specialist, a program manager, or a dementia coordinator means little in the grand scheme of things. Numerous state governments have established a dementia services position under a variety of names and through a variety of implementation methods, including statutory changes, inclusion in their state budget, and even repurposing an existing vacant position. Senator DeBoer did speak of the Alzheimer's Disease and Other Dementia Advisory Council, which, according to the law that went into effect last summer, was to have met by the end of 2022. However, council members have yet to hear of their first meeting or first steps. So we were elated to see that Governor Pillen's budget proposal included funding for a designated person at DHHS in the Public Health Division to coordinate for the Advisory Council, And we'd like to thank him for recognizing the need to prioritize the state's response to the growing Alzheimer's population in Nebraska. And so in conclusion, between 468 and the governor's budget proposal, it is our hope that the position will not only coordinate the council, but also be able to take on new dementia-related projects, such as applying for grants, federal grants, and assist with implementation of any future policy designed to help Nebraskans impacted by Alzheimer's. Things that, simply put, have not yet been able to occur yet.
Thank you.
Mhm.
Any questions? Senator Reapy.
Recently, there have been reported some research study that says that medical marijuana is an advantage for Alzheimer's patients on the agitation side. I just want some assurance that this is not a gateway to legalized marijuana.
Oh, absolutely not. I don't even think our organization has
a position on medical marijuana. So that's news to me, Senator. I hadn't heard that.
Okay, I'm being a little bit.
Okay.
Are there any other questions? Well, I'm disappointed by that answer, but I guess I'll,
Yeah,
Oh,
I'm sorry, Lake.
this is not a confessional.
But
okay.
Senator Reapy, if I may, you did ask a couple of questions earlier. I did want to circle back on those. If you could remind me what they were that you had asked Senator DeBoer earlier.
About the levels of the,
Well, my primary sense was, and I think you answered that and said, this person, I took concern over the fiscal note. I thought it was
yes.
particularly low.
Yes, fiscal note on the bill is comparable. However, the amount earmarked within LB 814, the governor's bill, was $100,000 even.
Is that what his was?
And it's to go to public health for the position.
So by the time you back out benefits, you're about down to 75. And I still contend.
Yeah, and
I'd argue with the government, you can't do it for 75, not have an FTE.
yeah, and I
Because
think
it won't end up with one. It'll end up with at least two.
yeah, and I don't think that the governor's proposal meant for this position to be director's level. To be honest, I'm not sure where the director's level language came from in 468. We never intended for it to be director's level.
Okay, thank you.
any other
Thank you.
questions? Seeing none, thank you for your testimony.
Thank you.
I'll take the next proponent of LB 468. Welcome.
Thank you. Good afternoon. My name is June Ryan, Juneryan, and I'm here today testifying in support of LB 468 on behalf of AARP Nebraska. AARP supports this legislation, a bill that will create the position of a state dementia director in the Department of Health and Human Services. As Nick stated, we do talk to each other. According to the Alzheimer's Association, we know that currently 35,000 Nebraskans over the age of 65 are living with Alzheimer's disease. Under the current trajectory, more than 13.8 million additional baby boomers are expected to develop dementia by 2050. A 2015 AARP policy survey revealed that virtually all of our members recognize that dementia is a serious problem, and that 85% know someone who has or had dementia. While members want to know about their mental functioning, and healthcare providers are the first line in the defense for individuals who notice a decline in cognitive health, few healthcare providers are really discussing dementia with their patients or assessing mental functioning during their annual Medicare wellness visit. Nearly half of our members mistakenly believe that dementia is a mental illness, and 41% think that dementia is a normal process of aging. The human societal and financial costs of dementia are all very high, including healthcare costs, impacts on individuals, their family and friends, and on the workforce. Currently, it's estimated that the average per person Medicare spending for people 65 and older with dementia is 3 times higher than that for seniors without dementia. Medicaid payments are 19 times higher. And research projects that the cost of caring for those with Alzheimer's will make up 24.2% of Medicare spending by 2040. Dementia not only impacts the patient, but also their families and friends. In 2015, the direct annual cost of caring for those with dementia was estimated to be $226 billion, with expectations that it will reach over 1.1 trillion by 2050. People caring for family or friends with dementia had $9 billion in additional healthcare costs of their own due to the physical and emotional toll of caregiving. And I just want to stop here for a minute and say that I personally am among many Nebraskans who served as a caregiver for a spouse with dementia. I would have appreciated knowing that Nebraska had a plan for educating and supporting families such as mine. But I was left to find my own support system and appropriate services for my husband, who had dementia that lasted for about 6 years before his death. It's the policy of AARP that policymakers should expand and bring to scale demonstrations that are cost-effective, person-centered, and proven to improve the quality of life for individuals all across the stages of the diseases that cause dementia. One of the goals of this program would be to delay the progression of dementia and increase independence through person-centered care while lowering overall healthcare costs. Dementia Centers for Excellence, which educate, conduct research, and expedite the adoption of cost-effective best practices, should be established and replicated. With the passage of LB 752, as was mentioned in the 2022 legislature, Nebraska created the Alzheimer's Disease and Other Dementia Advisory Council. The purpose of this council is to examine the needs of individuals with Alzheimer's and other dementia, the services available, and the ability of healthcare providers to meet the current and future needs of those with Alzheimer's and other dementia. LB 468 will provide this advisory council the support and the initiative to work to examine the needs and create a working plan for Nebraska moving forward in addressing and creating solutions for Nebraskans and their caregivers in addressing dementia and Alzheimer's in our state. Thank
Sorry.
you to Senator DeBoer.
Oh, there we go. Sorry.
I'm done. Thank you to Senator DeBoer for introducing this important legislation. And I'm
Thank you.
available to answer questions.
Are there any questions? I just have a comment, first of all. So thank you for your testimony. And also, I'm sorry for your loss. I know that oftentimes when we have someone with dementia and Alzheimer's, we lose them twice. So thank you for taking time to share your story with us.
Thank you.
Do we have any other proponents? Maybe someday. Welcome.
Thank you. Good afternoon. My name is Kirsten Reed. That's KIERSTINREED. And I am here to testify in support of LB 468. I serve as the president and CEO of Leading Age Nebraska. We are a statewide advocacy organization that supports long-term care providers across the state. In addition to my role as the CEO at Leading Age, I recently was also appointed to the Alzheimer's Disease and Other Dementias Advisory Council. I am also a family member of a person with dementia. My father was diagnosed with dementia nearly 10 years ago. So my appointment to the Advisory Council was both personal and professional. While this Advisory Council has been a recent development, there's been little movement in the Advisory Council. The bill for the development of that council was approved in the last legislative session, as you had heard, and to date, we have not had our first meeting. I've called the governor's office, I've emailed, I've asked questions in regard to the council, but I haven't received any answers. This could just be my lack of patience, but it could also be the need for more time to get this council underway. Unfortunately, my family does not have more time for Nebraska to understand that dementia needs to become a priority. Neither do the thousands of other family members caring for the 33,000 Nebraskans that are living with Alzheimer's and dementia disease in our state. I'd like to provide a little bit of history on where dementia services have come in Nebraska. So, as we talked about earlier, in 2014, there was a bill that was passed that organized a task force on aging. That is known as the Aging Nebraskans Task Force. Then in 2015, another bill was introduced, which then set in motion the implementation for those recommendations that were in that task force the previous year. And it provided the governance for the task force to then develop a state plan on dementia and Alzheimer's disease. So then that was done, and they did develop a state plan in 2015. The Nebraska State Plan for Alzheimer's disease and other dementia-related conditions that's posted on the state of Nebraska's website is dated June of 2016. The plan developed 3 main goals, multiple recommendations, and those were outlined to assure that residents that were living with dementia and their families had the information they needed to manage their lives, that they were provided the support to maintain their health and well-being, and that they were safe in the communities they lived in. To date, there have been no other updates on this plan. The goals and the recommendations that are outlined in that plan are relative, they are actionable, and they are necessary to ensure that Nebraskans that are living with dementia are able to live the good life. The problem is that most of the actions that are in there have never made it off the line of scrimmage. I believe that that's because we're missing that dedicated person to carry this ball. I believe that with dedicated resources, these actions are a reality, and that Nebraska could actually become a leader in dementia care and research. There are millions of dollars in grants and funding from the federal government and other private organizations that are already in existence. Nebraska is unable to leverage any of those because they lack the person to carry that ball to make that a reality. So to close, I'm here to support this bill, LB 468, to provide better resources and opportunities to those living with dementia and their families. We can do better, and we need to do better. The research in dementia is expanding, and we need to be ready to meet that goal. So I'll be happy to answer any questions that you have. Thanks for having me.
Thank you for your testimony. Are there any questions? Seeing none, thank you so much for being here today. Do we have any other proponents for LB 468? Seeing none, do we have any opponents for LB 468? Anyone in the neutral? Okay, and since Senator DeBoer has waived closing, we have 4 proponent letters for LB 468, and this will close the hearing on LB 468. And we will open our hearing on LB 353. And you're welcome to open, Senator Raybold.
It's so good to be back. Well, good afternoon, Vice Chair Kavanaugh and members of the Health and Human Services Committee. My name is Jane Raybold. Jane is Jane and Raybold, Raybould. I represent Legislative District 28 and appear before you today to introduce LB 353. LB 353 aims to provide grants of up to $250,000 to nursing or skilled nursing facilities to enable the acceptance of complex acute transitional patients to those facilities. To accomplish this, this bill asks for a one-time appropriation of $25 million. Ultimately, the goal of LB 353 is to support our hospitals and our nursing home providers across the state, and to also aid in the safe transition and necessary care for patients. There are currently 182 people waiting in the hospital to be discharged to a nursing home or long-term care provider. However, many of our long-term care providers lack the equipment and infrastructure to be able to receive complex patients from our hospital systems. These one-time funds would assist the long-term care providers to make these needed improvements. This in turn would assist with hospital capacity to allow them to be able to continue to support more acute patient needs. A facility interested in making improvements with this grant and funding would develop a memorandum of understanding with at least one hospital to accept complex acute transition patients into the facility. Obviously, their needs would need to match up between what they are able to do at the facility to improve capacity and the person that is seeking a placement. But this could open the door to new possibilities. The bill requests that the Department of Health and Human Services manage the grants based on the agreements between the long-term care facility and at least one hospital. Hopefully you'll hear testimony today from individuals representing long-term care facilities in our hospitals. They will be able to share more about how, as a legislator, prioritizing these one-time funds will be a huge investment in our nursing homes, the people they are caring for, and our state, now and in the future. And I want to say thank you so much for your time. And I know you have all heard and seen about the nursing home closing and shortages and workforce staffing issues. I know firsthand when my father was at Madonna in long-term care, I just remember they needed so many more pieces of equipment, lift equipment that would help those in long-term care, that would help the nursing team or the CNAs get their jobs done more efficiently and effectively. And I know in my mind, I can see exactly where one facility might take that $250,000 grant and probably build a new restroom facility that would have a whirlpool that would help these people perhaps in rehab or just make them feel more comfortable. And to create a bathroom to be able to accommodate a lift. I know that was high demand. All the patients in long-term care love that facility, but they only had one. They could easily take care of more patients and increase their comfort level if they could even build two more restrooms. So for me, I guess this is personal, and of course, I would be happy to answer any questions.
Thank you, Senator Raybold. Are there any questions? Yes, Senator Reapy.
Thank you, Chairwoman. My question is this 25 million in the governor's budget, or is it in possibly the legislators' budget?
I think it's in general funds, and I'm looking at the fiscal note that HHS prepared, and I know that they had estimated 3 FTEs to do this. I don't think that's quite necessary, and to be able to manage a grant, I think it is anticipated that there probably, there's quite a number of facilities out there, and I don't think we would have that number of requests come in for the 250,000. That 25 million, maybe only 50% of the 200 nursing homes would make that request for the funding, and I don't think that would necessarily require 3 full-time employees to be able to do that.
Is it in the, 25 million is not an insignificant amount. I don't know whether that's a line item in the governor's budget or Senator Clements is going to, through appropriations, put it in the legislature budget to sort of compare with the governor's spot and see where we end up.
I don't know the answer to that question,
Okay.
but I would be very happy to find out.
That's it. We'll find out probably soon enough as it goes along. The other question that I have is, do you or the people supporting you in this have a preference for, and this is an either or as I see it, is grants for $250,000 or Medicaid rate increases with the idea that you don't get both?
Well, I think, to be honest, all are necessary. And I don't know if I have another bill coming back in front of you for increasing the reimbursable rates to allow those nursing homes, particularly in the rural areas, to be viable and stay in business. So that's certainly a very a big priority that we need to take a serious look at
So
funding.
it's on top of this 25 million.
I would easily say it's going to be on top of that 25 million. And
That
of
could be a
course,
challenge.
there needs to be an adjustment in the wages too that will go in the reimbursable rate so that these nursing homes can stay viable. I look on it as economic reinvestment in these rural communities. If we want our rural areas to continue to thrive and be successful, this is something that is needed because we see more and more nursing homes close, and primarily in those rural communities. And oftentimes, those nursing homes are the largest employer in that community. And it's well known that the hospitals feed in to the nursing home or assisted living facilities for these transitional patients, but also works the other way around. The nursing home also feed into those community hospitals. And so, there's a great deal of synergy and codependency on each other. And both facilities are some of the largest employers in those rural communities. And so I look on it as economic reinvestment. You may look on it as a big expenditure and a big line item, but I think if we don't start looking at the reimbursable rates along with supporting grants that help our nursing home facilities take on patients, the cost will continue to rise because these patients are staying longer and longer periods of time in a hospital. And if you can imagine the hospital bill there, that starts to add up rather quickly. So there are tremendous costs if we don't start supporting these initiatives.
Well, I've given some thought to Medicaid reimbursement in nursing homes, and I think if we can move people into and through nursing homes, we can alleviate the burden that the hospitals experience of unpaid services to many patients they can't replace. My formula would say the more Medicaid you take, the higher your percentage of increase would be. And if you take 10%, I consider that charity, and that's maybe a 2% rate increase. If you take 50% Medicaid of your pay, then you might get a 10% rate increase. So it kind of gets down to a means test in a reverse manner for the providers in the nursing homes.
And I think the percentages that you're talking about are still insufficient to allow those rural nursing home facilities to stay viable.
So you're proposing a cost plus for them?
We know that the reimbursable rates are not even coming close to the actual daily costs to run a nursing home facility. And I think you probably know the numbers better than I do because of your experience as a hospital administrator. But we know right now that the reimbursable rates are not sufficient, even with an additional 10% increase. I think that's what you mentioned, to be able to help them stay viable. And I'm not a nursing home administrator. I've just seen some of the numbers. And like I said, to me, it's economic reinvestment in our rural communities.
Okay, thank you.
You bet.
Are there any other questions? I did want to note, we had a hearing this morning for Senator Brewer on LB 451, which was also a granting program. And I noticed that the same individual at HHS prepared both of your fiscal notes, and we might want to do some reconciling on their FTEs. So I just wanted to note that for the record. And we will take our first proponent. Thank you, Senator Rabel.
Thank you very much.
Welcome.
Thank you. Thank you very much, members of the Health and Human Services Committee. My name is Margaret Weppel, MargaretWeppel, and I am the Vice President of Workforce, Quality, and Data at the Nebraska Hospital Association. I am testifying in support of LB 353. After hearing numerous anecdotal stories about the difficulty transferring patients out of the hospital and into a post-acute setting, the Nebraska Hospital Association began collecting monthly data from their hospitals in the fall of 2022. According to the monthly data, there has been consistently approximately 230 patients waiting longer than 7 days post-discharge for placement. The majority of these 230 patient delays are attributed to delays getting admitted to a skilled nursing or a long-term care facility. Of note, in January of this year, 2023, 18 of those 230 total patients have been waiting at the wrong level of care in a hospital for over 6 months to be placed in a post-acute setting. In the summer of 2022, the Nebraska Hospital Association launched a Transitions of Care Council to monitor and provide solutions for this issue. Members of this council include hospitals and post-acute professional association representatives. During these meetings, we learned that one significant barrier to post-acute placement is Nebraska's aging post-acute facilities. These facilities are simply not equipped with the necessary infrastructure to take on certain complex patients. For example, a bariatric patient requires patient lifts, as we've kind of talked about already, wide doors to accommodate extra large wheelchairs, weight-supported chairs and toilets, among other things. Many of our Nebraska facilities do not have the existing infrastructure nor the capital funding to accommodate the needs of a bariatric patient. Other complex patient capital needs include items such as IV pumps, ventilators, and wound care devices. The Nebraska Hospital Association supports a grant specific to projects that increase post-acute facilities' capabilities to support complex patient types. Hospitals and post-acute settings working together to assure the most appropriate setting for patients is good for all Nebraskans. Thank you very much, and I will take any questions.
Thank you for your testimony. Senator Reapy.
I guess my first question, I think I heard you, correct me where I'm wrong, you talked about some access issues, if you will.
Yes.
That would seem to me a gross violation of the ADA, that, the American Disabilities Act. And I don't know how they would comply with codes to be able to even qualify to be a nursing home if they can't accommodate ADA patients. The other question that I would have is, you talked about the problem of placement of patients.
Mm-hmm.
My question is that, can you break that down just a little bit for this? Is that primarily of getting people back home in
Good
rural
question.
Nebraska as opposed to urban Nebraska?
Home meaning to post-acute
Well,
nursing home or long-term
Say
care.
if they live in, picking Hastings, and they happen to be at Bryan or St. E's here in Lincoln, is that a bigger problem for them to find a nursing home in Hastings or maybe even a smaller community than it is, say, in a larger market like Omaha?
Absolutely.
Now, there's also the affordability. It's finding a bed is one thing, but finding an affordable bed is a totally different story.
Yeah.
You can find one if you've got a lot of money.
Yes. Well, your first question, I am not an ADA expert, but I am a nurse, and I do work with quality in
Nurses know
hospitals.
everything.
And so what we're talking about ADA is the ability to get in and out of rooms, but then the limitations come in those extra large bariatric patients. And so older facilities were not built in the manner of which Nebraskans and the whole United States are growing in weight. We're seeing heavier patients, and these nursing homes were built in the time in which patients just weren't necessarily that heavy. So they can accommodate, wheelchairs and a patient type of the older generation, but not necessarily the ability to keep up with how we're changing. We're sicker, we're heavier, and that's throughout the United States. We have done some analysis to your second question, and there are some differences. It is a little bit more difficult to get placement in certain populations, and that is because there's a gap of nursing homes. So we have a monthly throughput survey, and in certain districts, there are just no nursing homes or post-acute placement in multiple counties, especially out west. So the lack of nursing homes and in the western part of the state is really creating a significant issue on beds in general, let alone beds for medically complex patients. Some of the facilities in the Lincoln and Omaha area are newer. They've been built more recently, so they do have some of the infrastructure. For example, a lift, we not only have to take the lift, but what about the actual ceiling and the supports? Can they support a 600-pound patient? In the older facilities, we're finding that they're not. And that's where this grant would serve us in just updating those. And so we can get more rooms. They don't have to have every room able to take a medically complex patient, but maybe one or two. Does that answer your questions?
Yes, I think so.
Okay. Thank you.
Thank you. Any other questions? Senator Ballard.
Thank you, Senator Kavanaugh. What's off the top of your head, what would be the demand for this grant? There's possible 100 grants that could be administered. Would the grant be obsolete in a year, 2 years, 10 years?
That's a great question. I think I'm going to defer to those behind me who are in the nursing home business. I do know that the majority, so every month we've collected data. There's been 230 approximately patients waiting for discharge, and the majority, 80% or more of them, have been waiting for post-acute placement in a long-term care or skilled nursing. So there would be a great need on the hospital side. We see that. As for how willing and how many post-acute placements are willing to say, hey, yeah, we would like to go into partnership with a facility to take on a bariatric patient or complex wound care. I don't know, but I bet those behind me can answer.
Are there any other questions? Seeing none, thank you for your testimony.
Thank you very much.
We will take the next proponent for LB 353. Welcome back.
Thank you for having me again. All right, good afternoon, Senator Kavanaugh and the committee. Again, my name is Kirsten Reed, KIERSTINREED, and I still serve as the president and CEO of Leading Age Nebraska. Leading Age is a statewide advocacy organization for providers of long-term care services, including nursing homes. And I am here today to testify in support of LB 353. This bill is being brought forward to establish tangible outcomes to address the backlog of patients that remain at the hospital because they are unable to find placement at a long-term care provider due to those complex medical conditions. So according to our colleagues that you already heard from at the Nebraska Hospital Association, when I pulled this data, there were 227 patients that were awaiting discharge, and 182 of those were seeking nursing home or long-term care placement. These delays are for a multitude of reasons, but one of those is their complex care needs put them in a situation that a nursing home is simply just not being paid enough to support their complex care needs and to support the infrastructure that needs to be put in place to get there. So some of these needs would include one-on-one supervision, bariatric care, psychiatric care, dialysis, transportation barriers, and currently even COVID quarantine has been an issue. So this bill would provide grant funds for long-term care facilities to be able to make modifications, infrastructure improvements to the facility, and to be able to provide the needs of long-term care patients. When a person is supported through a nursing home, it becomes the responsibility of the nursing home to address all of their needs for care, treatment, anything that they need ongoing. This can mean equipment, staffing, supervision, even the cost of medication, and much more. So the risk and the expense of supporting someone with a complex medical condition far outweighs the payment that the nursing home receives for their daily care. Our nursing homes are just simply not in a position to purchase new equipment to support someone or modify their location or train additional personnel on the complex needs of some of these referrals. So I'd like to give a couple examples of how this could be used. One type of patient that Margaret was speaking about is someone that has a bariatric condition, and that means that they are significantly overweight. This condition requires a nursing home to have oversized bed, wheelchair, a scale, a lift. All of those things have to be able to handle that increased weight. Doorways might need to be widened for these patients as well. With these grant funds, a nursing home could invest in the equipment or the modifications that they need to make to 1 or 2 rooms within their program to be able to support someone with these conditions. Another area that we haven't really talked about is psychiatric needs. So patients with psychiatric diagnosis are sometimes difficult to discharge, and there simply are not enough geriatric psychiatric services in our state. And the majority of our nursing homes in our state are not secure facilities. So using these funds, they could provide additional security, supervision, specialized training to be able to meet the needs of those with significant psychiatric and sometimes behavioral issues. This would allow for more robust psychiatric services. Bottom line is our nursing homes do have beds available and they are able to take on more patients, but they need assistance in being able to meet the needs of those patients. A lot of that is coming from the upfront cost of the complex medical conditions. So I look forward to seeing this move forward. I'm happy to answer any questions that you have. Thank you.
Hi.
Hi.
Thank you for your testimony.
Yeah.
Are there any questions from the committee?
Over here.
Yes, Senator Reed.
Senator, thank you. This might be a comment. It seems to me that one of the strengths in your argument might be which is very common in nursing homes, the workplace injuries to backs because of lifting and, as a worker get off balance and they're out for weeks on end.
Absolutely.
Maybe that'll come to the Business and Labor Committee.
Wow, that's a good one. That would have been nice. And yes, that's a huge issue. And then the more injuries that they have among their workforce, the higher their work comp rates get, which also means that that's just more money that they
Just loss of FTE.
Yes, and they've got employees that are out. Geriatric psychiatric issues are one of the main reasons. There's folks that are sitting in the hospital for long periods of time because they may not need a secure facility, but you're all in Health and Human Services. You've all heard that they don't look good on paper referral. This is what we deal with. When someone doesn't look like someone that you can easily support with what you're being paid, your likelihood to take that person in is pretty low. And you had a question earlier that I think I have an answer to.
Great, yes.
If
I may, Mr. Chairman?
Yes, you may, Senator Ballard.
The same question. I will ask a question. What would be the demand for this grant?
Great question. So we, when we were talking about the framework for this, we started out at $100,000 per grant. You can't really get a lot done with $100,000. So we moved it up to 250 really felt like a good place to be. You can make the modifications that we need to make with $250,000. You can purchase the piece of equipment that probably costs $250,000 to buy some of this equipment. Demand, we set it up so that, like you said, 100, which is roughly half of the nursing facilities that would be able to access this on that budget. We're envisioning this being one-time use, and it is specifically to address this hospital capacity that we're dealing with right now. My suggestion would be to make it 1 year, 18 months, 24 months, somewhere around there so that we can get it out, get it used. And then if there's unused money, then that can go back. That would be my idea for it. Now, how many of those 100 would take us up on this? staffing is a huge issue, and we've talked about the finances for Medicaid and some of those services. So I do think that that's a concern. They have to be able to staff the bed along with taking that person in. But I do think that there would be, we've talked to our membership, and there's several that have said, yes, we will absolutely put in something for this.
Okay. Thank you.
Yes, Senator Reed.
Thank you, Chairman. How many nursing homes are now owned by and funded by county boards?
Well, that is a wonderful question.
Well, thank you.
I don't know how many are funded through county boards specifically. We can definitely look into that. Leading Age, actually, for many years, up until last year, we only accepted nonprofits. So we do serve a lot of those as our members that are county, city operated. The hospitals own some of them. We have a variety, but 99% of our membership at Leading Age is all nonprofit organizations, and they support 80% of their patients that they support are Medicaid.
It's a tough number.
Yes.
Any other questions?
Thank you. Thank you.
I'm seeing none. Thank you for testifying.
Thank you.
Is there anybody else who wishes to testify in support? Welcome.
Thank you. Good afternoon. And thank you to Senator Rabel for introducing this bill. It's encouraging to hear your understanding of what we experience every day in long-term care, so I appreciate you. Thank you. Well, good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Lois Jordan, LOISJORDAN, and I'm the President and CEO for Midwest Geriatrics, which operates Florence Home Healthcare Center, Royal Oaks Assisted Living, House of Hope Assisted Living, and Memory Care in Omaha. We are members of Leading Age Nebraska, and I serve as the president on the Leading Age Board of Directors. Thank you for the opportunity to testify on LB 353. Florence Home Healthcare Center is a nonprofit mission-driven organization that provides skilled nursing and long-term care services for 95 to 100 seniors in Nebraska. More than 80% of the individuals we serve are eligible for Medicaid. LB 353 aims to provide grants to nursing and skilled nursing facilities to facilitate the acceptance of complex acute transitional patients to those facilities. As Ms. Reed mentioned in her testimony, Nebraska hospitals experience significant delays in transitioning patients to the next level of care when their acute care needs have been met and they're ready for discharge. Nursing homes such as ours, Florence Home, need those referrals and admissions to stay in business, and yet we must decline to admit some of these individuals when the cost of their care will far exceed our reimbursement, or there is no payer or payment source to cover the cost of their care. As a result, individuals remain in the hospital longer than is medically necessary, or they may transition to their home before they're 100% ready, resulting in a higher risk of readmission to the hospital when attempts to live independently are not successful. If approved, this bill would assist nursing homes such as ours to make modifications to our nursing homes so that we could accept those individuals that we currently decline due to structural limitations, staffing needs, no payer, or insufficient reimbursement for that level of care needed. For example, individuals may be prescribed medications or treatments that far exceed our daily reimbursement rate. Additional funds to supplement our daily reimbursement rate would allow us to cover the cost of such medications or treatments. Funding could be used to support structural changes, as was mentioned, for bariatric care, such as widening doorways or purchasing those specialized bariatric beds, wheelchairs, and lifts. And we are ADA compliant. However, as Margaret had mentioned, ADA compliance, we're doing that daily, but for the individual who requires a lift that can go beyond a max of 500 pounds would need to be a specialized lift. If they're in a wheelchair and we need to transport them somewhere, their weight plus the wheelchair weight would exceed the weight that our lift on our van could accommodate. And so those issues are kind of at the end of or outside of the spectrum of what we've been able to care for. We may be able to serve more individuals with psychiatric and behavioral needs if nursing homes are reimbursed at a level that would compensate for one-on-one caregiver support. To accommodate individuals who are COVID positive, nursing homes must dedicate a specific area of their building to isolate that individual from the general population. Creating that separate and distinct area of the nursing home is very costly. In addition, you must have dedicated staff for that isolation area and to ensure greater infection control and less risk of spreading this virus. All of these modifications require funds we do not have. Funding from this bill would ensure citizens of Nebraska can safely transition to the next most appropriate level of care following a hospital stay. Please accept my testimony in support of LB 353. Thank you.
Thank you for testifying. Are there any questions from the committee?
Sir,
Senator
I
Rubio?
have one. You mentioned about the wheelchair or the van lift.
Sure.
So I'm seeking clarification here. Would the money be flexible to be, doesn't have to necessarily be used on the facility to make it, put another bathing area or another widening doors? You could use it on a lift or a program?
That's my
Is
understanding.
that your understanding?
Yes. that's
So
my
that gives it
understanding.
quite a bit of flexibility as well.
Sure.
Okay, thank you.
And if we have to transport them back to their doctor's office for a visit and accommodate them in our vehicle, we'd need the lift that could
Okay.
do that.
Now, do you have, I assume you have a physician contract or medical director that comes to the,
We do if they would switch providers to that, but they have a choice of providers. So if they wanted to stay with their physician that they were with in the hospital or prior to their hospital, their primary care physician's been with them, they can stay with that physician and they may not come to our facility. They may want them to come to the building, to their clinic.
but my opinion is if they choose to stay with their private physician, God love them for it, it's their obligation to get there and get home. They can't, I don't think they should be able to pass that burden on to you as the provider and run up your cost, but that's my personal.
I wish it
I'm
could
a
be that way,
hard-nosed
but yeah,
administrator.
we're obligated to get them to the physician of their
You're
choice.
obligated because you want to be. I
No,
don't think
because
there's
we're
any-
dictated to.
Pardon?
We're dictated to. We have to. We can't force them to change to a different physician.
Only because they're Medicaid?
No, because CMS tells us we can't force them to change a physician.
Federal government, okay. Thank you.
All right, thank you.
Any other questions from the committee? Good, Senator Blount? Okay. All right. Okay, thank you for your testimony. Is there anybody else wishing to testify in support of LB 353? Is there anybody wishing to testify in opposition to LB 353? Is there anybody wishing to testify in neutral capacity? Seeing none, well, welcome Senator Raybold up to close. I'm so glad I made it back. I had so
Oh,
many
I am-
questions for you.
I am thrilled to see you, Senator Hanson. So I think at the beginning of my testimony, we established that right now, this snapshot in time, we have 182 patients that need to be transferred out of the hospitals and into additional facilities. And Senator Ballard, you had a great question. So how could we leverage this funding? So I think we know that there's a little more than 200 nursing homes. If 100 of those nursing homes took us up on this grant program, and hopefully they modify their facilities and say they could add 2 more beds, that would be 200 beds. That would take care of the 182 that are currently waiting in the hospital and racking up costs. And I know that the question, I think Senator Repe, you had asked about the vans, but this funding can go to those vehicles that will help transport those individuals, particularly the bariatric patients that need a larger vehicle. But, and I know you had a question about ADA. I just know that when you have the electric lifts, they're a little bit bigger. They can fit inside an ADA compliant door, but they're still big. And if you have a larger patient, and since I'm in the grocery business and we have forklifts, can you imagine, for a larger patient, you will need to have some type of mass that will be able to balance that weight and load to be able to transport or transfer that person safely. You had a great question about the governor's budget. Is it in the governor's budget? And my answer was, I don't know, and I still don't know. But I wanted to say that we have that capability. We have general funds that we could put it in. We have what could be one of the most historic surplus of funding to go towards the seniors or the most vulnerable patients that are our obligation to take care of. So there's multiple avenues. Besides the governor's budget, we as legislatures have the funding authority as well, with how we spend our dollars. And I can't think of a better way, like I've said before, about economic reinvestment in our healthcare as well as taking care of those in our community.
Okay, thank you.
You're welcome.
Thank you. Are there any other questions from the committee? I have one.
Yes, sir.
Is there any other funds you've looked at to pay for this besides general fund? Cash funds or any other kind of, I'm just kind of curious.
I have not. Is there other funds I could look at?
There's a whole bunch of funds
Like-
up, but of course, if you touch
At-
them, you're gonna have 80 people come after you.
Okay.
But I don't know.
I just thought because we have a tremendous surplus, but if there's other funds, I would be more than happy to go
Isn't
after
there a
them.
healthcare fund?
There's a healthcare cash fund, but if you touch
Hey,
that,
hey,
if you touch that, Sarah Howard, I think personally will
Everything's
kind of
up for
find you.
grabs.
Okay. So that's a
if you have
no,
conflict of interest,
probably, but if there are other funds,
Depends
I'd
how bold you
certainly,
want to be. I don't know.
I would love to chat with you about other funds and their availability. Since I'm new to this, I'm not
Yeah.
sure what other funds I
Aggressive
could tap into,
fiscal
but
You
I'm all
never know.
ears.
Like it takes some from, I just kind of curious if people looked at it. So, okay.
Okay.
Seeing no other questions, thank you very much.
Thank you all very much.
All right, and for the record, there were 4 letters in support, 1 in opposition, and 2 neutral to LB 353. So with that, that will close our hearing on LB 353 and our hearing for this afternoon. Wow.
Are you 30?
Evidently, I hit a